Can you hear me?
I can. Can you hear me okay?
Perfect. Yeah, I can hear you great.
Okay.
Yeah. Have you been doing tons of like press this week and last week?
I've not been doing a ton, but like collectively as a group. So the Cape, like we have a public affairs committee who fields all the media requests.
Okay.
And I've long been kind of lingering in the background a little bit. But I finally started doing a little bit this week, which has been good.
Good.
Yeah,
Yeah,
yeah.
no, that's great. Did you guys intentionally put out your statement with the Kai report, or was that just a coincidence?
It was, we were hoping honestly to get it out a little bit ahead of Kai, I think, but like
Okay.
we were knowledgeable that Kai's report was coming.
Yeah.
We just had a national forum in early May in Toronto, where Kai was present and with a lot of like leadership from across Canada. So like what we've kind of done this thing now twice where we invite decision makers and policy and political leaders from across the country and kind of have a day with them. And so this is the second one. And Kai was there. They had actually specifically
Okay.
reached out to us, and it just the timing worked perfectly. So Kai came and shared their data with us, and then we formed some working groups and stuff with them to try to enhance the data collection and
Good.
metrics and things like that.
Yeah,
So,
good. Yeah,
yeah.
it's always good when people that are working on similar things can work together
Oh,
instead of working in
the
silos, hey?
the Kai thing has been fantastic though. Like, because it's always one thing when it comes from us, but it's so much more when it comes from other people, right? Like sometimes you feel
Yes.
like people are sick of hearing from physicians
Yes.
or sick about hearing about the ED, but like when you get completely other bodies saying like, "Hey guys, this is a
Same thing.
problem." Like
Hmm.
that's yeah.
Yeah,
So,
that's good. That's good.
yeah.
Okay, so let's go back a little
Okay.
bit.
Yeah.
I just read your bio from the U of S webpage. I
Okay.
was like, how are you not 135 years old for all this education? So, how did you make the loop from being born and raised in Saskatoon and then like coming all the way back to Saskatoon with the specialty that you have?
Yeah, so I was born here, as you said. I left after my undergraduate degree, as many people do, with a little bit of a lost soul. I did microbiology and loved it, but then wasn't quite sure where I was going with it. So I ended up doing a master's in public health, which was a natural transition with epidemiology and kind of public health thoughts in microbiology and infectious disease. And in my public health realm is actually when I first got involved in care of older adults. And that specifically was about dementia care and dementia policy and design from a like kind of regional health authority level in Scotland. And so that was my first kind of delve into some of the challenges that older people specifically face. And then
Wow.
I did med school in England and didn't realize till quite late in my medical school that I was planning on coming back to Canada. And so I moved to Ottawa and did my residency there and a 5-year program in emergency medicine, and then into Toronto where I stumbled. I shouldn't say stumbled. It was somewhat of an organic transition into my geriatrics fellowship. When I entered emergency medicine, care of older adults was something I actually talked about in my interview. And it honestly seemed a bit far-fetched at that point. Nobody was
Hmm.
talking about it. It was just something that I realized with my public health hat on that the society's aging and we're not ready. And none of what I learned in medical school and the early parts of residency was specifically tailored to the care of this like very important and very large group of our population. And later on, I went to meet with Don Milady, who was my mentor in Toronto for my geriatrics fellowship, and I had planned to go with him for 2 months to do some geriatrics work. And after one conversation with him, I signed up for a year and moved to Toronto.
Wow. Wow.
Yeah. So yeah, I did the fellowship in geriatrics in Toronto and wanted to always head out west. Wasn't specifically looking to return to Saskatoon or Saskatchewan at that point, but was very fortunate in that I had some allies and supporters and sponsors here in Saskatchewan who really helped to
Yeah.
drive a position and develop a position for me here.
So do you spend most of your time then in the emergency department? Like, is that where your work is?
Yes, my
Okay.
clinical work is solely in the ED.
Okay.
And then I have like administrative work as well, and I also do some transport medicine as
Okay.
well. So,
Okay.
but clinically, it's largely emergency department based.
Okay. So, as we've seen this week, the ED waits are back in the news. It was sort of all over the media last week talking about the long wait times nationally. Everybody's struggling with it. And I
Mhm.
was wondering, could you sort of give people a glimpse of what that pathway looks like for an older patient that presents to emerge with like whatever you kind of see commonly
Mhm.
and how they talk a lot about alternate level of care, but I don't know if people really know what that means. How they tend to get like stuck in the system, and then
Yeah.
how that affects full circle back to the emergency department. Because I'm not sure people have the whole pathway laid out. And
Yeah.
often people just think, well, make a bigger emergency room or add an
Yeah.
urgent care center or like
Yeah.
tell people not to come to the emergency room because it's too busy. So, can you describe what that looks like so people kind of get the full understanding of it?
Absolutely. I mean, I think this may come up as like a couple different scenarios.
Sure.
Um, I think one of the easy cases to kind of talk about is starting with an older adult in the community who resides in their own home.
Okay.
So, most older people want to be at home.
Mm-hmm.
They want to maintain their independence. They want to be at home. And they want to be at home with the minimal amount of supports that they need,
Mm-hmm.
typically. And so when they do require supports, they usually are requiring supports on a fairly time sensitive basis because they've kind of gotten to that point where things are needed. So the first hurdle they come up against is the fact that well over 10% wait more than a month to get home care. So if an
Wow.
older adult needs assistance with getting up and bathing, for example, and they can no longer achieve that, they can't wait a month to get out of bed and to get some personal care.
Mhm.
And so that may end up with them coming to emergency department because
Right.
there's nowhere else for them to go. And so at times, older adults present, with that sort of a story where they lack social and community supports, or it may be that they have complex health needs and they've got an infection, for example, a pneumonia, an influenza, COVID,
Mm,
and that just tips them over the scale to be
mm.
no longer independent. But again, they can't manage at home, so they end up in our emergency departments. We medically assess them, we treat them, we assess their home environment the best we can, take a social history, etc. But ultimately, these patients often need to become admitted to the emergency department.
Because there's no one in the community that could give them the support that they need in that timely way. Is
Correct.
that often the barrier? They
Correct.
need supports and then those supports aren't available.
Correct.
Okay.
Yeah. And
Okay.
so that is improving, I would say.
Okay.
But probably, we've seen the demographic shift coming for, well, 60 to 80 years
Forever.
now.
Yes. Yes.
And so we haven't grown and evolved our services to keep in line with that. And so if an older adult requires admission, and say particularly if they have mild cognitive impairment or dementia, or maybe they've developed a delirium as a result of their medical issue, they will require a bed upstairs. But there are no beds upstairs in the hospital. And I say upstairs, I mean in an inpatient admitted bed in
Mhm.
our hospital. So if there's no admitted bed for them to go to, or no admission bed that they, as in their care system, deems appropriate for them, they wait. And they wait in our emergency departments. And they wait in our emergency department hallways. And they wait for days. Because
Mhm.
often these older adults are not ones that require observation units or cardiac monitoring, for example. They require a hospital bed and the supports that the hospital can provide. And so if there's no bed upstairs, they wait in our departments. Well, what would happen to any of us if we sat in a hallway for 48 hours with lights on, people walking by?
Yeah.
We can all imagine that we might become sleep deprived. We might not be getting up and moving. We
You're
might,
on a stretcher lots of the
yeah,
time. So,
yeah.
like, those are so uncomfortable.
Yeah, well, it takes an older adult less than 1 hour to develop things like pressure ulcers or begin to develop
Wow.
skin breakdown because their skin, is typically very different from the skin of a younger adult or younger
Yeah.
person. And so we know that the longer they wait in the ED, the more complications, the higher risk of death within 30 days, the higher risk of developing delirium or an acute confusional state, which comes with a single episode, increases the risk of developing dementia in the long term,
Mm-hmm.
pressure ulcers, etc. They functionally decline. So they came to the emergency department with a state where they needed some support, and they're leaving departments with a state of needing even more support.
Right.
And then they get admitted to hospital, and if they sit there for even longer, that circle kind of continues. They're not getting up and moving. They're continuing to functionally decline. Um,
They
and
might not have a window to be able to see
they might not have a
outside.
window. Yeah,
Yeah.
hospitals are not safe places that we
Yeah.
commonly think they are. Sometimes I hear people say, well, we're going to be admitting them for safety. And I say, okay, that's fantastic. Can we just talk about safety for a minute and what safety means? Because some people need to be admitted. I 100% agree with that. But I think is opportunity for admission avoidance with appropriate timely access to community services. But the other problem we're seeing, as you kind of alluded to, is this alternate level of care. So we know that roughly 10% of hospital admissions end up in people being labeled as alternate level of care. And what that essentially means is that their medical care is complete. They have no medical need to stay in hospital, but they now have a care need that cannot be met in the community. And so they remain in hospital waiting for whatever need that is to be met. Typically, alternate level of care patients, about 80 to 90% of them are older adults. And many of those are waiting for long-term care. Now, I take that with a little bit of a caveat because I think they're waiting for long-term care because no better alternate exists.
Right.
Many
Or
older
did they decline so much that they actually need long-term care, whereas they might not have if they had just been supported in their home?
Absolutely. I think that is a
Yeah.
real possibility. We don't have good evidence to
Yeah.
drive that argument, but certainly anecdotally, we see it happening, right? We see
Hmm.
people entering hospital in one state and leaving hospital in a very diminished, declined state. And some of that is likely due to the acute illness, their multimorbidity and complexity that, would have happened anyways.
Yeah.
But certainly, I think that in many ways, we're lacking the support and care that we know that older adults need to prevent functional decline, to prevent loss of muscle mass, to
Mm.
get them up and moving, to ensure their caloric dietary needs are met, etc. And so I do think some of that decline is avoidable that happens in
Mhm.
hospital. Um, and then they wait longer. And then the longer they wait, the worse they get. And then they'll never get back to that independent state that they may have come into hospital with.
Yes. And they might have just come in with a UTI and then it just like progresses from
It can be
there.
such a simple thing, right?
Yeah.
It could be a virus, a common cold.
Yeah.
When you're older and you're living with a lot of medical complexity, it doesn't take much to kind of drop your independence just enough to mean that you need more supports. And if we can't get those supports in place in a timely fashion, then often we're left with no other choice than admitting to hospital.
Right. Okay. Okay, that is a great explanation. Are there any interventions or things that people can do in Emerge to kind of get them out faster, get them assessed? Are there things that are helping?
Absolutely. There's a whole host of models of care that are going on around the country that are really impacting the way older adults move through our care system, including in our emergency departments. So, for example, having a geriatrics team based in the ED that will
Mhm.
kind of screen for and proactively assess patients to try to determine from the moment they set foot in that door what it's going to take to get them home successfully. And I mean successfully because it's not just a matter of getting them home, right? They need to be home and to have the supports to remain home. And so models like that, there's fantastic ones going on in Eastern Canada that have been shown to really reduce the chances of patients getting admitted and to increase the chances of them going home in a like durable fashion where they're not just bouncing back or having unplanned visits back into the emergency department. So having geriatric support within the ED, that can be ideally like a multidisciplinary team where we have things like a physician, a nurse to guide care, as well as allied health, physiotherapy, occupational therapy, pharmacy. So this is happening in, I'd say, largely bigger centers across Canada.
Okay.
And then there's various models that also I think can be adapted. For example, a pharmacist doesn't necessarily need to be based in the emergency department, but this is something that could potentially happen in a virtual care model. So for
Mhm.
our smaller departments, there's opportunities that exist there, even to provide more of a wraparound multidisciplinary service. Ontario has a geriatrics emergency nurse program where most emergency departments in Ontario have a GEM nurse, it's called,
Okay.
um, who, come and they do various roles adapted to the specific needs of their departments. But typically, they're nurses who've undergone extra training in care of older adults. And they're able to take that time to do a bit of a mini comprehensive assessment to really focus in on a lot of the things that it's really difficult to do in the ED as a physician. So, for
Mhm.
example, I don't often have a lot of time to call family members to really get a comprehensive history, to really see what's going on in that home that might be impacting care or impacting the ability for us to get that patient successfully discharged. I won't have time necessarily to ensure the patient's family doctor can see them in the next few days upon discharge, for example. But
Right.
having it as somebody who's specialized in that area that can provide that care is fantastic and really can be impactful for older adults who come into our departments.
What would you like to see available, like in a perfect world? What models would you need in the community that you would feel comfortable and happy releasing your patients back into?
I think a lot of things. So first, like, is just timely access to even basic care needs. So timely access to ensuring that, somebody can be assisted to get up in the morning and to get their morning medications, for example. And the same sort of thing in the evening, assisting them getting back to bed and ensuring that they've had their medications. But
Mhm.
it's so much more than that. It's so much more than just the very basic needs that we often think about. It's things like physiotherapy. It's things like having a home falls assessment. Patients can wait multiple months. We're talking 6+ months to have somebody come into their home to aid them, to make sure that there's no trip hazards, like little carpets, like
Right.
lighting cords, like good lighting, to put up handrails, to raise toilet seats, things that are really essential to allow older adults to maintain their independence and mobility and to prevent them from having further falls, for example. So timely access to services like that as well. Um, I think at times it's just a matter of making sure that the patient has access to a reassessment in a short period of time
Mhm.
to know that somebody's checking in on them. Not all older adults are fortunate enough to have family members or friends who can check in on
Mhm.
them. And that sounds like a simple thing, but it's, when your care might depend on that, when you need to know if that patient is doing okay and is managing at home, then that can be the difference between coming into hospital or not. And again, I think services are improving at this, but I think it's pretty piecemeal.
Yeah.
And I think one of the great challenges is actually knowing what is available and trusting that what services are available are going to do the task that is required. Our healthcare system still depends on faxing.
I
Like,
know.
we're
I know.
faxing
I
these
know.
these requests that patients are dependent upon and just trusting that somebody on the other side of this is receiving it and acting on it in appropriate fashion. And that's not a good feeling as a provider when you're, accepting risk in the interest of a patient to try to get them home.
Yeah. Yeah. I interviewed Dr. Ginger Reddy a few weeks ago. We talked about
Okay.
the patient health home
Mhm.
and, how you would have a place where people knew you and had a history with you and would be flagged as soon as you went to the emergency department so they could connect with the emergency department, be like,
Yep.
it's okay. We know them, we've got them. We can connect with home care and get them sorted out if you can do what you need to do and we'll take care of them.
Oh, wow. Oh, yes. Like, you're almost talking about a universal record system, for example, where
Oh,
we can actually see what's going on with people across the entire
right.
spectrum of care,
Right, right.
which would be a huge step. I think the other thing to remember from an emergency point of view is that we operate 24 hours a day, 7 days a week, 365
Yes.
days a year. And unfortunately, the rest of the healthcare and community care systems do not.
Yes.
And so that creates problems. Even our acute care hospitals typically don't run effectively outside the hours of, say, 8 a.m. to 4 p.m.
Yeah.
You know,
Yeah.
discharges don't happen, patients don't move. Access to our allied health services, which are
Mhm.
integral to everybody's care, particularly older adults,
Mm.
is limited. Weekends, you walk into a hospital on the weekend, it's a very different place to a hospital during the week in terms of the hustle and bustle and work that's
Right.
going on. And that
Right.
just gives you that overall sense of what is happening. And it's a very quiet space, oftentimes.
And I remember even working on medicine, like everybody would get discharged Friday afternoons. Like the doctors would come in and make their rounds, everybody would get discharged Friday afternoon. And then we were sending them on a weekend where
Mhm.
there was
Mhm.
nothing in place for them. Do you
Mhm.
think home care is suffering from a shortage of people, a lack of investment, a lack of prioritization? Like, is acute care just sucking up all the resources? Is it hard to shift from acute care? Like, I just see, so many places investing in capital and buildings and
Mhm.
beds. And then I just keep thinking, well, no one wants to be in those beds. People want to be at home. Like, is it a
Yeah.
better use of our resources to be putting that into home care, or is that just not on the radar?
I mean, I've been in practice now for just over 7 years.
Hmm.
Um, and what I've typically seen is further and further restrictions in many ways on like what it is that home care actually does in
Okay.
various provinces, and how much care they can actually provide. So, a number of provinces have time restrictions. You can receive 14 hours of home care a week, or that may be temporarily increased to 21, but that's not a durable solution, for example. And the things that home care can typically do is quite restricted. So, for example, many home care services um, don't provide any form of like light cleaning or housekeeping or anything like that. Well,
Okay.
that's a pretty important part of independence around the home. And if it's really difficult for you from a mobility point of view to pick something up off the ground that you've dropped, whether that's a handkerchief or a piece of toast, that can really evolve into an unsafe environment
Yes.
pretty quickly. Um, I do think that there's been a lack of investment in home care. Um, well, care aid workers, however you want to call them, healthcare workers, support
Mm.
workers, care aides, are an essential part of our healthcare system,
Mhm.
but they're actually not. If you look on paper, they're not. They're part of our community care system. So home care and long-term care aren't even kind of invested in terms of healthcare, right? This is a separate portfolio with a separate budget, with a separate political leadership portfolio. And so I think that creates a lot of challenges as well when we start to silo out these services that are so interdependent.
Mhm.
And in doing that, we're starting to reduce our understanding of the needs of our population and how those needs are and are not being met. I would love to see care aides get better training, get more
Yeah.
investment within them as individuals, not only in recognition of the importance of the work that they do, but to make it a safer environment for them to promote more longevity and to also financially remunerate them in a way that
Yes.
recognizes their work. You talk to some and you can make more money working in a fast food place than you
Yes.
can providing this essential service for so many vulnerable people in our communities. And that to me just doesn't sit right. But we see that even in our acute care hospitals and the emergency departments. If I talk to colleagues who are across the country, we know that we don't have the number of care aides to support our patients that we would like to have. And typically there's gaps in schedules. So for example, the impact of that might be in the emergency department is if I have an older adult presenting to a department who's confused, who has a delirium or an acute confusional state as a result of their illness, that's something that is typically temporary but very impactful. That might look like for somebody who's not familiar with delirium, that might look like an older adult who's laying in a bed calling out frequently,
Yeah.
saying
Hmm.
help, help, help. Um, and then somebody goes in and they're not sure what they're needing or what's going on. That might look like an older adult trying to climb out of a bed. They just want to go
Hmm.
home. They don't know where they are. It might look like somebody, trying to take off their leads and their monitors, take their IVs out, for example. And so a lot of these behaviors can be very challenging. They're challenging for the older adult, they're challenging for family members, and they're challenging for the care team.
Yeah.
The good news is typically with these sorts of behaviors, redirection is very effective.
Mm.
So if somebody could be there just to redirect them, to engage them in other ways, then that would be it. That's all we need. So a care aide is somebody who would be trained specifically in that and able to provide that. when we don't have these care aids, it creates an unsafe environment, particularly for the older adult who may become increasingly agitated. But it also creates an unsafe environment because our teams in our departments don't have the time always to provide that care. You know, if they get an acutely unwell patient that needs full assessment and nursing, then suddenly this older adult is left somewhat less attended.
Right.
And the solution can often be things like restraints, which we know are harmful.
Mm.
And that can be physical restraints or that can be chemical restraints or medications to sedate. And so what we're seeing is something so simple as a lack of care aides, for example, who are, as I said, essential care workers, can have devastating consequences. You know, now you put an older adult in restraints, they try to get out of bed, but now they're tethered and they can't get out of bed and they fall and they hurt
Right.
something.
Yeah.
Or they don't move and they develop a pressure ulcer because they're now laying in bed without the ability to move themselves safely.
Mm.
You know, so many of these small things are not
Mhm.
small at all and are
Mhm.
so impactful.
Yeah, absolutely. I also heard about a program called the Hospital Elder Life Program. Were you
Mhm.
involved in developing that?
We developed no, so the HELP program was developed by a lady named Sharon Inouye,
Okay.
out of the US, and that is a service that would be amazing. So, for those who aren't familiar, the HELP program is kind of a more comprehensive wraparound program that provides um, assessment and kind of like acknowledgement of the needs of older adults, and then targeted interventions to try to reduce the risks of hospitalization, improve their function. So not only not diminish function, but actually improve function when they're in hospital. And to perform all of those other tasks that are typically missed in an acute hospital setting where we just focus on the medical component of patients. So frequent mobilization, socialization, interaction, cognitive exercises, et cetera, et
Games
cetera.
and yeah,
Yeah, like
reading the newspaper and
all the
yeah.
things that like we as humans need and
Yes.
like and these programs have been shown to reduce the risk of developing things like delirium, to help patients get home healthier and faster. And so when I was working in Toronto, there was a similar program in the hospital I worked in, and then what we did is we actually took that and developed an ED based volunteer program that focused on providing a lot of those same services. So providing older adults with things that some might say are comfort items, but actually, if comfort means sleep and sleep means recovery, then these are essential components of healthcare. You
Yeah.
know, so things like having a warm blanket, because emergency departments are often cold, you know, providing them with high calorie snacks and treats, you know, crosswords, word searches, as well as social interaction, assisting them in eating, because oftentimes, as we said, there's not a lot of time and people who can assist in these really important things. And so those are certainly like the help program or variations of that. And there are many, but the help is probably the best studied ones, are evidence-based and have actually been shown to be cost neutral, essentially,
Right.
right?
Yes.
So, you know, having an older adult not stay an extra 4 days in hospital is actually a really good use of resources.
Yes. I remember when I was on ED Weights and Patient Flow Initiative, that was one of the programs that actually, when we modeled it, actually had an impact. Like that was one of the
Yeah.
big, like blaring, blinking red lights. Like we could do this, we could do this. I've
Mhm.
shared it with so many people in the system that I could think of because particularly in Saskatoon, the university is right beside RUA, like, right, very close to the hospitals, right?
Yeah.
So I'm like, what if we could take students and train them to, and they
Mhm.
all need volunteer for whatever education or healthcare, whatever.
Mhm.
And it was things that I thought were so interesting, like making sure people's glasses are clean and their hearing aids have batteries in them and that are working and they get in the morning,
Yeah.
to avoid the confusion, writing the date, taking them for a walk. Like I almost think of like when I was a teenager and I did candy striping. Like
Yeah.
that was kind of what we
Yeah.
did as candy
Yeah.
stripers, right?
Yeah.
And I
Yeah.
didn't think it was really an important role, but now that I see it actually is. Like the
It's
nurses don't have time.
No, it's super
Yeah.
important. Absolutely. And all the things that you talked about, you know, we're developing things like these geriatric carts, we call them, you know, where we have, instead of having a suture cart or a resuscitation cart, we have a
Hmm.
geriatrics cart, and it has all of those super duper important things. It has essentially temporary hearing assistive devices. It
Okay.
has batteries for hearing aids. It has reading glasses, sleeping mask, earplugs. all the things that are not just specific for older adults, but in some ways, older adults are the more vulnerable.
Yeah.
Um, we started this talk on talking like a little bit about CIHI, the Canadian Institute for Health Informatics, about some of the data that's coming out there, and studies from around the world. And we know that essentially the longer you stay in the emergency department, not only like the greater risk of dying, the greater risk of developing delirium, but also the greater risk of staying for a longer duration in hospital. Um,
Right.
and I think a lot of that is due to things that are avoidable, like sleep, like sensory deprivation.
Mm,
And I think the data will continue to come out now that hallway medicine has unfortunately become a normalized
mm,
part
mhm.
of our healthcare system. It's actually interesting if you talk to people across the country, they're not called hallways anymore, they're called pods, or
Yes.
or they're called
Yes.
treatment space X, or
Yes.
you've taken a cubby and assigned it a treatment space, and so that how
Mhm.
somehow seems to make it more acceptable. But we know that the harms and the risks are just the same, and in fact, in the hallways, they're so much probably worse. If our healthcare system, one of my colleagues, Dr. Catherine Varner, wrote a really interesting editorial on this recently. But if you think of a healthcare system right now that in many ways is struggling to provide good care to our current population,
Yeah.
and then you add in an event like a potential war, for example,
Yeah.
where we're having hundreds, if not thousands, of soldiers being repatriated for medical care,
Mhm.
and we currently can't function. So how are we
Mhm.
going to provide that care to these individuals? And
Yeah,
where
it's
is
like
that?
it's a national risk.
It's a
Really,
national
it
risk.
is a
Yeah.
national to have a system that's not functioning and not
Yeah. And I
working for
think that
us.
the ED, the challenges that we face in the emergency department, the term like the canary in the coal mine is often thrown around because we really are, I think, the temperature gauge for the rest of the
Yeah.
system.
Yeah.
Because when everybody else says no, we say yes.
Yeah.
And we will always say yes. But I will say, as a provider, it's disheartening. We talk about moral fatigue and burnout.
Mm.
Everybody I know that works in an emergency department is there because they care,
Mm.
because they want to do the job that they were trained to do. But I think when you start to see harm, and you start to be unable to perform to the level that you would expect of yourself and your colleagues, that's pretty injurious for most of us.
Yeah.
Um, and so we are seeing national shortages of physicians, of nurses across the country, of care aides, etc. And again, I think that's a symptom of an underlying critical condition of our
Mhm.
healthcare system.
Mhm. Yeah. Yes. And as I said, that canary is ashes now, right? Like that
Yeah,
canary
I know.
died a long time ago. And we're at a point now where it is really about like survival. And I don't know if people have the sense of urgency that many people in the healthcare system do,
Yeah,
because they don't see it, or they only really, if they have an experience, maybe it kind of wakes them up. But like Stephen Lewis said, people aren't sort of marching in the streets yet, but it'll start affecting you for
absolutely.
sure. Yeah.
Oh, absolutely. I think what people need to think about when it comes to emergency department wait times and overcapacity is really that the emergency department is like a straw. What goes in one end of the straw must come out the other end.
Yes.
And so if somebody comes into our department, the number of people that go out needs to equal the number of people who come in order for our patients to flow and receive appropriate care.
Mhm.
And so when we get these lower acuity injuries, that people think, oh, well, it's all the people who aren't using the EDs appropriately that
Yes.
are driving overcapacity and access block. It's the people with the pneumonia, it's the people with the infections, etc. Well, that's not the problem, because if you imagine, they come in and they go out and they go
Mhm.
home. That's
Mhm.
simple, that's not leading. What's happening is we're getting our populations of everybody, whether that's social deprivation, whether that's mental health, whether
Yeah.
that's older adults that come in and need to be admitted, but they're not, right? There's
Yeah.
nowhere for them to go. And so the number of people coming in is not equating to the number of people leaving.
Mm-hmm.
And that's what causes our access block. That's what causes our overcapacity. That's what causes people in our waiting rooms to be waiting 5+ hours. You know, our patients to suffer harm in departments across our country. So it's not a symptom of the number of people coming into our departments. Sure, you might wait a little bit longer at times, but that's not the problem, right?
Yes. Yeah.
That's why we triage, and that's why we do things to, select who gets seen first. But when
Right.
I no longer have a bed to assess a patient in because they're all occupied by inpatients, that's a problem,
Yes. Yeah.
you know.
So, if you had your way, if you were the boss of healthcare, what would you want to change or do? Would you want to do sort of the simpler things like get help in every hospital in Canada? Would you want to restructure something? Where would the biggest bang for our buck be if we wanted to do something?
I think so. I I need a lot of bucks, but I think that no, I do like I
Well, we
think
have
that
8.5
yeah,
billion that we just put in Saskatchewan, right?
fair,
Like that's a lot
yeah.
of bucks.
It is a lot of bucks. And I do like I think whatever happens, the first thing is it needs to be a system-wide conversation.
Okay.
It can't be siloed.
Yeah.
It can't be an investment in one area without an assessment of what that looks like downstream and what
Mm.
that's impacting. So I think the first thing I would do is I would get all my community acute care, long-term care, I'd get all my partners at the table.
Yeah.
Because I don't know if that happens frequently enough, and I don't know if we have a true integrated community and healthcare system.
Yeah.
And I think until we understand the needs of one another, we're not going to improve anything. And so I think that'd be a big thing. The other thing I think I would do is yeah, I'd focus on kind of harm prevention when it comes to hospital and moving patients through. We alluded to this before, but if you ask, 80-90% of older adults, they don't want to be in long-term care, right? So the 85% of ALC patients that are over the age of 55 in our hospitals that are probably the vast majority awaiting long-term care placement, that's not where they want to be. They want to be at home in a really heavily supported environment. And systems that do that well have been shown to actually be more cost effective than places like long-term care.
Mm-hmm.
But we're talking about a system overhaul, right? We're talking about taking a system of acute care that was developed for acute medical, fairly simple problems and
Transactional kinds of
transactional
Yeah.
exchanges. Yeah.
Yeah.
And we're talking about recognizing that the needs of our populations have changed.
Mhm.
And along with the needs, there's not really been a change in service provision.
Yes. Yeah.
And so I think that that's a big thing to do. It's not simple. Are there small things we can do along the way? Absolutely. For example, things like transitional care spaces. Let's not admit them to an acute care hospital where they don't really get physio and occupational therapy and all the things. Maybe there's a space in the community where we can provide a more resource-intensive support and we can get them
Mhm.
up and moving and get them home faster. Or maybe that can happen in hospital and we just develop our services to wrap around, kind of like a help type service.
Yeah.
But having services that are more specifically designed to meet the needs of the population rather than providing kind of a one size fits all approach
Right.
to support older adults or any of our complex needs patients.
Yeah. Yeah.
So like going back, I think I would, we do need, don't get me wrong, we probably need more long-term care beds.
Mm-hmm.
Some, right?
Mm-hmm. Mm-hmm.
But that is not the only part of this problem.
Mm.
We probably do need more acute care beds. In fact, we know we do, right? We're running per capita less acute care beds now than we were previously.
Mhm.
And similar thing to long-term care. So we probably do need more of these. But we also need much more in terms of community supports, home care, keeping people in their own homes for longer.
Yeah. 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 It's like seeing the problem together, right? Like, yes, acute care beds, but
Mhm.
also building in that home support. And
Mhm.
sometimes where I see the disconnect is that everybody's focused on that as being the solution, where it's part of a solution, but the solution is really in the restructuring of the whole way we've designed the system.
Yeah, which I don't know. Well,
Big.
I'm optimistic. I don't.
Well, you can't work in healthcare and not have some level of optimism.
Delusional optimism, maybe,
Delusional optimism. That's right.
that's okay.
Yeah.
I do like. I I think the more and more attention these issues get, the better it is.
Yeah. Yeah.
And
Yeah. And you have been a real leader in this space. And I think the things that Cape is doing and you guys are putting out and all the interviews that you can do, the more that we all understand the system, the better it is. And when solutions come to the table, we can really think about if that's what we want as a community, as a
yeah,
province, as a country.
yeah. No, I couldn't agree more. I think people are smarter than a lot of leaders sometimes give them credit for,
Yes.
and should have more autonomy in decision making regarding their health and healthcare.
Yes.
And it's, even things like a bit controversial, but like ED closures, for example, and like how we share with our communities across Canada if their emergency department is closed, or if in fact it's being covered by a virtual physician as opposed to an in-person physician, to try to allow them to make decisions that they feel is best for their care.
Yeah.
Now,
Yeah.
that comes with like a little bit of a double-edged sword, and sometimes, everybody gets it wrong. But I think that um, people need to be a little bit more vocal about the challenges that they see, the things that they disagree with, and what it might look like moving forward for them. It shouldn't take somebody dying in a waiting room for stories to make headlines. It
Yeah.
shouldn't take an older adult sitting in a hallway for 72 hours for stories to make headlines, for change to happen.
Yeah.
And as you see, I mean, you're very well into this life as well, with these headlines come and they go,
Yeah.
and then they
Yeah.
come and they go. And then there's an inquisition, and the same 16 recommendations are made, and then they come and they go. And I mean, I've only been doing this for 7 years, and I see it already. And
Yeah.
so,
Yeah.
like,
Even there's a idea around living with risk and
absolutely.
how comfortable you are in being like, I want to go to my own home and I
Oh,
accept the risk. And as
oh,
healthcare, we don't want people to do that. We institutionalize them because
oh,
that's the safest place for them, or we put them in the hospital because we think that's the safest place for them. And people are like, you know what? I'm good. I'm 93 years old. Like, I just
yeah.
want to go home.
Oh,
Like,
I
if
have,
I fall
oh, this
down,
is,
I fall down. And, yeah, we have to
th-
get used to that too.
this is
Letting
my
people make choice.
conversation, 100%, right? Like,
Yeah.
I have this conversation, I would say, every shift,
With
every
the
shift,
patients or
with the
with the
patient,
system.
with the patients, with their family members,
Yeah.
because often an older adult will come to the department, and a very well-intentioned family member will say, well, I think it's unsafe if mom goes home.
Hmm.
And so I kind of will take a minute to explore that with them and think and try to figure out what they're concerned about in terms of safety.
Hmm.
And, sometimes it's as black and white as having a conversation of, you know, your mom's risk of falling at home is at least the same in hospital here. If
Right.
if not potentially a little bit more, right? Because now you're putting your mom in an unfamiliar environment,
Yeah.
where
Noisy.
they don't know where that side table is, where they don't know where
Mm.
that door frame is. Um, and so, like, hospitals are dangerous places,
Yeah.
and there's very good data to support that.
Yeah.
And so I think understanding what the risk is, and older adults are allowed to live at risk, right? Like, for some
Yes.
reason, there's this rendering, like, paternalistic nature of care of, you know, I, thou healthcare provider, know best, come into a hospital where you will be safe. But that's not what hospitals
The
are
real
anymore.
experience. Yeah.
And even if they are maybe a little bit safer, if an older adult wants to go home, I will do everything I can to support them to get
Hmm.
home.
Hmm.
And yeah, they may fall, but they might have fallen 2 weeks ago, and they might fall 2 years from now.
Yeah. Or
And
they
I
might have fallen on admission.
Yeah, and I
Yeah.
think trying to manage that risk and have those conversations with them, And it's unfortunate, but now I often see patients coming in, they need admission. They need services that can only be provided in an acute care hospital. And they're like, I am not staying in this hospital. I am not staying in that hallway. You will not be admitting me. I am going home.
Yes.
And so in some ways, it's actually like the mentality is flipped for a lot of people, and they're actually losing a little bit of trust in our system.
Yeah.
And that's a really sad and potentially dangerous place to be as well. And I also, as a provider, will have very strong conversations with those individuals and explaining that I appreciate that they're motivated to get home and I'm glad they are. But,
Yeah.
I think that in this instance, the risk outweighs the benefit, and we should really focus on trying to get them stay motivated, and hopefully that it's a brief admission. As long
Yeah.
as you're motivated, you're up, you're moving, you're doing the things.
Yeah.
But I completely agree. Those risk conversations are super duper important. I think if you ask, like, honestly, almost every emergency physician I know, if you said, like, do you love it? I love my job.
Yes.
I love being an ED doc. It's a special type of work. It's just one of those things I think that people love when you find it.
Mm-hmm.
If you are one, you love it.
Mm-hmm.
Um, but like you said, like it's different when you want to do so much more.
And you're constrained by the system. Yeah. Well, thank you so much for taking the time with me today. And I'm sure you're hopefully off for summer holidays a little bit, hopefully, as we head into
24/7.
July. Well, I will be sure to get this out to leverage the attention it's been getting in the media in the last couple of weeks. And hopefully people will take some time over their holidays on a long drive, maybe just to listen and consider what kind of system we need to build and how we can maybe get there together.
Awesome. Yeah. Let me know if there's anything further.
Thank you so much.